So basically when you have an ectopia lentis, you have either two options with you. Either you save the bag or you go away with the bag and go in with the secondary intraocular lens fixation. When you are going ahead with the saving of the capsular bag, the options that you have in your armamentarium is the rings, the segments and the hooks. And when it comes to secondary IOL fixation, you have lots of choices coming up if you're going up primarily for that procedure. So when it comes to secondary IOL fixation and when it comes to me, the best thing that I do and what gives excellent results in my hand is the glued IOL procedure. And why it is so is because I have detected on high-speed photography that there is no pseudophygognosis coming up with a perfectly done glued intrascleral fixation of an intraocular lens. And this was my paper that got published last year in the Journal of Cataract and Refractive Surgery. And like we have demonstrated this on high-speed photography with an iPhone that pseudophygognosis is not seen in glued intrascleral fixation of intraocular lens. I think this video itself is also not running, probably. This is just an image which I'm trying to show. This is the post-op photograph of a glued intrascleral fixation. Actually what happens is on high-speed photography you can detect subtle intraocular changes which are going on, but you can see even as the patient moves his eye, the intraocular lens is not moving in the eye, and this is one of the reasons why I choose glued IOL to be my procedure of choice when I take up the cases for surgery. So I'll just wind up with this and I'll go ahead with my video presentation. My first video that is coming up is a case. This was actually a child which I had taken up for the surgery, and the child had a massive subluxation of the lens. Now this is the status that is there in the intraocular lens, in the eye. So the first thing that we do in these cases is that we will always measure the white to white diameter, because usually these cases are with Marfan's or any other syndromes that is associated, and we might have large eyes. And when you have a large eye, there is a limitation to the glued scleral technique. You know, I pause my video here. We have a limitation here because we do not have an intraocular lens that is specially designed for this procedure, and we always use a 3-piece intraocular lens, and the lens 3-piece which is currently available in the market with the maximum diameter is about 13 millimeter. So that is all that we have. And suppose if you have an eye of 13 millimeter, how do you go ahead with the surgery with a lens exactly of the same diameter? So we have an option to this, how we go ahead with this. This is again, as it was mentioned before, this is the trocar anterior chamber maintainer. We try to have an infusion into the eye, and we try to use this because the best part about this is that it never ever tends to come out of the eye. It does not depend upon the size of the side port incision that you have created in the eye. It remains as it is, and till the surgeon himself or herself expels it out of the eye. So this is a continuous infusion that is going on. And now I am again pausing my video here for one simple reason, that before I proceed, I want to tell you that this is a large eye, and what we are now going to do, this is one of the paper which is just coming up in JCRS. When we have such large eyes, we try to do anterior sclerotomy, which has already been published before. When you do an anterior sclerotomy, that means you are entering at the level of the base of the iris, and maybe when you do it, you will definitely damage the base of the iris, the root of the iris. So in order to avoid that, we try to do a peripheral iridectomy. So that is what is now going on the next stage for this case. But I am known for creating complications and then handling all my complications myself, so half of things are created by me only. Now I am going ahead. I'm trying to do a peripheral iridectomy in this case. This we do at the proposed site of sclerotomy. But what happens here, the entire iris tissue comes up into the probe. So I have myself created a complete iridectomy instead of a peripheral iridectomy. And on the other side, now I'm scared, I do not want to go ahead with that. So what I try to do is that I will try to do an anterior sclerotomy, but I try to go more vertically so that I do not tend to damage the root of the iris. Going ahead with this procedure, now it's the routine procedure that we try to do. For these cases, we try to introduce 23 gauge vitrectomy cutter from the sclerotomy incision itself. We try to do into that plane. This is basically a pars plica vitrectomy that is going on. Now when we take up these cases, you have to be very careful when you're doing vitrectomy and eating up the lens beneath the iris, because you tend to involve that tissue also into it, and that is what has happened into this case. So once I know I have to handle my iris, but that I'll be doing it in a later on stage. So in this stage, I've just taken up a 3-piece intraocular lens and I'm going ahead with the glue dowel procedure. This is again my technique of doing it. This is a no assistant technique which got published in JCRS 2013. I just flex the haptic more towards 6 o'clock position, so my leading haptic lies free out there with no assistant to hold it, so I end up with less complications that tend to come up with the haptics and all. So once I have tried to do this, I have externalized this with the handshake technique once both the haptics are out. When you work at an anterior plane, you can see the amount of haptic that was externalized in this case. We had a greater amount of haptic coming up. So that's an advantage that we get when we try to do anterior sclerotomy. But as I said before, you have to be very careful with the iris tissue because you should not be damaging it at any point of stage. So once I have done and I am done with my IOL fixation, I know my half of the battle is won out there. I have tucked it. But now what I tend to do is I need to mend the mess that I created myself. So I have to repair the iris the iris tissue out here. But in this case, what I was trying to find was that the iris tissue was also very friable, but somehow I carried it on and I tried to do a modified Seepser slip knot technique, and I tried to fix up the iris tissue out there, creating an intraocular knot inside, and then cutting up that knot and trying to give a perfect shape to the iris tissue and to the pupil, because it is very important to prevent this, and especially this was a kid, and you need to prevent any post-operative glare that comes up in these cases. So once the iris tissue is created, actually in this case, I was trying to hurry up and trying to finish up the case because I was a child and the patient was under sedation and going on, and I was advised by the anesthetist that I should be finishing up the case fast, but actually I should have taken one more suture in the iris and try to close the peripheral tissue itself also. But anyway, somehow the surgery was done, and we have done fibrin glue application has been done beneath the sclerotomy, beneath the flaps, and it has healed up very well. And I'll also show you the post-operative picture of the same patient. The patient is doing quite well now, has even this is the post-operative image of the patient after a week. So that looks pretty good, and the patient is scheduled for surgery next week for the other eye. I'll show you one more case, again a child. Now this was something very peculiar that I saw, not very peculiar, but rarely we tend to see these cases in our practice. In fact, again a bilateral association in a young girl. Now in this case, this girl, she had a wandering lens, a spherophakic wandering lens. When the girl would sit or bend her head down, the lens would come in the anterior chamber, and when she would lie down, it would go into the posterior chamber. So like I was in a fix how to go ahead with this case, try to make this patient in a seating position. I tried to put pilocarpine also, so that let the pupil constrict, let it remain into the anterior chamber, so that I can just finish off things in the anterior chamber itself, and I don't have to go ahead with the posterior chamber involvement and all. But actually such a thing, the pupil never constricted. I do not know, somehow it remained at the same level. So I had to take up the case, and we definitely knew that in this case we have a posterior segment involvement, so we have to go ahead with the surgery. So we have just taken up the case. Pars plana incisions have been created with the infusion inside the eye, and a good amount of vitrectomy that is being done in this case. You have to be, you can see this lens, it's a very soft lens because it's a young girl, so we knew that this is just going to come up in the vitrectomy probe. You do not need anything much for this case. So but when you try to handle these cases, you know, the vitreous sedations, they are very strong in young patients. So you have to be very careful while going ahead and doing the vitrectomy. The entire vitreous surrounding the nucleus, the lens has to be removed first, and then after that you can just involve the procedure of lensectomy. You can just proceed with that procedure of lensectomy. As you saw before, triamcinolone staining was also done because you really do not want to have any push and pull at that point of stage. So once you know that the entire nucleus has been gone and you have done a good amount of vitrectomy, so now it's again a simple case. Again, you have to do that's what I do, a glued fixation for this case. So in this case, typically I have created a scleral pocket before I made a corneal incision. That is what I used to do before when I was in my learning phase, because you know what used to happen is later on I used to find the eye to be quite soft, and I used to at times struggle making a pocket and then tucking the haptic inside. So I used to make that before. This is again a similar procedure, but it's a very important procedure. A 3-piece intraocular lens is being unfolded inside the eye, and you grasp the tip of the leading haptic from the left sclerotomy side. You just have to be there. You don't have to fasten up your skills at this point of time, because unless and until the entire intraocular lens has unfolded inside the eye, you're not supposed to pull the leading haptic out of the sclerotomy side. Once you have done this, then you just flex the trailing haptic inside. Now this is, I did this case when there was no handshake, when there was no assistant technique with me at that point of time. So once both the haptics are externalized, then it's a very simple thing. Let me tell you one thing, all those people who are either doing or all those people who are doing, they already know this, but all those people who are now attempting to go into this, I would like to say that the strength of this fixation comes up only from the intrascleral haptic tuck, and that has to be perfect, and that has to be an adequate tucking in the pocket that has to come up in all the cases, because if the tucking is not good, your glue is no way going to help you, and you are going to land up with either a haptic problem or a decentered intraocular lens or something. Once your haptic tucking is good, everything is good for your patient and for you also. So this is the post-operative image of the patient, and the patient is again doing quite well. I think, thank you so much. I end up my presentation with this.